నేనే మాట్లాడుతుంటే
Ashok garu speaker view pettagalana for everybody. Shilpa ma'am, whenever you're talking only, you keep the video on, so that otherwise Dr. Vijay sir's he'll alone be seen. Because if at all you make any movement, then picture will change automatically. So when you're talking, you can start the video. And once you're done, when sir is about to start, sir will on his video. Yeah, thank you. We can start off. You're ready, sir? Let's start, sir. Sir, you're on mute, sir.
Yes, I'm always ready.
Over to you, Shilpa ma'am.
Well, good evening, everybody. I'm very delighted, and at the same time, I feel very privileged to have the opportunity to kind of share this platform with my guru and mentor, Dr. Vijay Anand Reddy, sir. Well, today's topic for discussion, which has been given to us, is about the recent developments in the management of cancer. Well, as we know that oncology is an expanding avenue, and there have been a lot of advances in the oncology treatment. So my job in the next 45 minutes would be to get a glance of these developments from our experts' perspective, which will be in terms of what are the advances in terms of surgical, radiation, and medical oncology has whatever developments we have seen in the recent past. Well, good evening, sir.
Good evening.
We are very happy to have you on this platform.
Pleasure.
Well, sir, shall we over to you, sir, with the questions? To start off the discussion, I would like to just ask you, as we are hearing a lot that in the present era, the oncology management is mainly called as personalized medicine, or it is more customized to the patient's molecular way of dealing. So what is your take on what exactly is the personalized medicine?
Yeah, good afternoon and good evening, and thank you for the wonderful opportunity. In the past, when the cancer was treated, we were just looking at a biopsy which says that it is a cancer. There are gone with those days where we just treat a patient with a diagnosis of just having a cancer, but we need to, a lot of developments happened in the field of pathology. Now we know from what is the origin of the cancer, from where it is arisen from. Although in most of the instances where we don't even know where the tumor has started from, we have plenty of molecular studies in the pathology level itself, which is called immunohistochemistry, where we can identify the cell of origin from where the tumor has started from. And also that in most of the instances where we have a metastatic disease and we do not have the primary detected, and where there will be a lot of dilemma, how to treat, how to go about with the treatments. And so that in that way, the immunohistochemistry in the pathology has made huge impact on the diagnosis of cancer. And also the precisely which when we know that what type of cell the origin is from and how the tumor is going to behave and how the treatment has to be aggressive, whether it is a very low-grade disease, whether it is a very high-grade disease, the proliferative index. There's so many things that have come in the pathology which guide the clinician how to target that particular patient. instead of a generalized kind of a treatment. So in that way, we also get to know that whether this tumor is going to be sensitive to radiation, it's going to be sensitive to chemotherapy, and it's the best way to go for surgery. So in that way, we all will get to know various forms of modality of treatment that can be advised in that particular patient. Now, beyond that, we have gone beyond pathology, IHCs, to molecular status. So identifying the targets within the cell is the era of what we call it as a precision medicine, where we would like to know how the tumor has been started from, how it is originated from, which is the target that actually is mutated, which is transformed, which is a reason for converting a normal cell into a tumor cell, and can we inhibit that particular target. So identifying the targets where the mutation has happened within the cell is very, very important to look at the precisely treating that particular, stopping that proliferation at that molecular level helps immensely in controlling the cancer. That is called the precision medicine. So there are so many targets within the a tumor cell which can be identified, which can be targeted by means of precision medicine. So it's like a signature. So any patient who has got a cancer, and that particular patient, what kind of tumor cell it is and what kind of a molecular targets that can be targeted in that particular patient to get the best outcome. And not only that, the most important thing is that by targeting that kind of precision, targeting the molecule, we are able to reduce the side effects by avoiding a generalized form of treatment. That means, in other words, when you do a kind of treatment, a blanket treatment, where the normal cell as well as the cancer cell are going to be affected by doing this generalized treatment, is now with the precision medicine, we are able to target precisely the cancer cell and the molecule which is disturbing the cell to convert into a cancer, or which is causing the proliferation of that particular cell. So this is called the precision medicine. We have come a long way, and I still feel the long way, the road ahead to get into more and more details of this precision medicine. And nowadays, we look at multiple genetic abnormalities within the tumor cell as well. We call it as next generation sequencing, where we look at multiple genomic modulations and moderations and deletions that are happening within the tumor cell. So it's an average of 400 genes are tested these days to identify these targets, and in that way we will be able to identify the mutations. We are able to identify the targets which we are able to precisely focus on them to get the best outcome. So it has become an order of the day that to identify or to ask for these genetic abnormalities, gene abnormalities within the tumor cell. Although it is a little expensive, and but it does make a difference, especially in rare tumors where we really don't know what could be the best way of treating those patients. So and also in a patient who is in a complex manner where patient is not responding to the standard treatment, in such indication, in such patients as well, we look at the possibilities of doing this genetic testing, which is called as next generation sequencing, to identify any kind of new, abnormal, unusual mutations within the tumor cell, where we can target them precisely and to get a better outcome in these particular patients. Yes, Dr. Shilpa.
Well, thank you, sir. That was quite an elaborative answer. It was quite helpful. Well, moving ahead, as you have rightly said about the personalized medicine, in terms of multimodal management of oncology patients, it involves surgeon, radiation oncologist, and a medical oncologist. What, according to your expertise, has been the newer invention or something which has made a real-time impact on the clinical practice in terms of surgical outcomes? What is that advance in surgery which we have noticed?
Again, going back to 2 decades back, earlier we used to have large kind of surgeries. You call it as an amputation or removal of the total breast, removal of the larynx, removal of the entire rectum with the colostomies. So you name it, you have it. So radical surgeries were the concept in the past, where they used to think that the more you remove, the more chance of a cure. Now we understand the biology of a tumor. It is not just removing the entire tumor. We need to take a tumor as a systemic disease. That means that it is not just a local disease, but it's a loco-regional and a systemic disease. When I say loco-regional, that means removal of just the breast does not make any sense. You're looking at the lymph node drainage area, and you are looking at the blood vessels which are supplying the breast cancer. So similarly, every cancer, primarily the blood vessels and the lymphatics and the drainage lymph nodes and the dissemination that can happen from there to other parts of the body. So in that case, when you treat a patient, treat a cancer, we should always look at a comprehensive way how we can deal with this patient: local control, loco-regional control, and a systemic disease. That means it should not allow to be spread to other parts of the body. So when you say that loco-regional is important and systemic disease is also important, we don't need to do radical surgeries, radical amputative surgeries. So that has moved from radical surgeries to conservative surgeries. Conservative surgeries means that as much as possible, as less as possible, without causing functional abnormality, without causing disfigurement. So that is a goal of now today's surgery, where we do conservative management and minimal operative morbidity. Patient gets admitted on a day and then get discharged the next day. So that from laparotomies to laparoscopy or minimal invasive surgeries, and then from there we moved on to robotic surgeries. So robotic surgeries is the way of where every other tumor nowadays we have been doing robotic surgeries. The greatest advantage of robotic surgeries, where the hands cannot reach, where the laparoscopy cannot reach, the robotic arms can reach. And a human has got 2 hands and 10 fingers, whereas a robotic arm has got 10 arms and 40 fingers. So that's the way it is more precise, where you can reach the cornermost part of your body. We can reach the smallest of the small blood vessels. In that way, the bleeding is less, the morbidity is less, the recovery is very, very fast once you do a robotic surgery. And that is not, we are not compromising on excision of the tumor. Precisely, the tumor is excised with less morbidity and least blood loss. So the recovery is very, very fast. So in that way, we are conserving the organ and function, and with a minimal morbidity. That is the goal of today's surgical oncology.
Well, yes, sir. So rightly so, I think surgery has seen mainly robotics as the game changer for them, and even the bigger surgeries, something like radical prostatectomies and hysterectomies, are being now done very easily through robotics. And well, moving ahead, in terms of radiation therapy, what exactly now in radiation oncology, radiation therapy treatment delivery has become quite precise, and we are now moving towards delivering the treatment in shorter durations and lesser number of visits of the patient to the hospital. So in that perspective, what do you think, how much is too much, or how much is too long for a patient to come for radiation to the hospital?
Right. So the radiation has got, purely controlled by computer technology. The computer technology is a phenomenal changes happened in the recent past. So and so in the delivering methods, the radiation can be delivered to the patient. So it has become more precise, and we can command and dictate where the radiation can be given, how much dose of radiation can be given to each part in the area of where the radiation is being given. We can actually dose paint and dictate and deliver whatever we think and whatever we want to do in that particular area where the radiation has to be delivered. So that is called the real revolution in radiation has happened because of the radiation being modulated in the area where the radiation is being delivered. For example, you have a tumor in the nasopharyngeal area, that means a small tumor behind the nose, and then you have to deliver high dose of radiation in that area, and then you have to protect both the eyes, optic nerves, and the brain besides this nasopharyngeal tumor. And apart from that, you need to treat the entire drainage area from the nasopharynx to the entire neck. So there are some nodes which are involved. There are some nodes which are expected to be involved. So you can deliver radiation in piecemeal in different areas, different doses, and protecting the critical structures in the large area of the radiation from here to lower part of the neck. Although we are treating the entire area, we are dose painting and delivering the dose, what is required and what is not required. For example, the larynx and the throat will be completely spared when you're treating the nasopharyngeal area. So that kind of a technology is available these days. That's called intensity of radiation being modulated. Whatever dose that is delivered every day, for example, 200 centigrade is delivered in different areas, different doses, and no radiation in certain areas. So that is called intensity of radiation being modulated. Besides that, whatever is being done outside the treatment area, it to be precisely being done on when the patient is on the couch. That is called image-guided radiation treatment. The patient's treatment is planned outside in a seat with a CT scan, an MRI scan, and a PET scan. And then we plan different kinds of beams on a computer. And finally, we come into a solution, a plan where we want to deliver that onto the particular patient. So the same thing, although we do quality assurance, everything is done outside a patient's treatment room. So that has to be precisely delivered when the patient is lying down on the couch. So how is that possible? That is exactly possible these days, which is called image-guided radiation treatment. So image-guided radiation treatment is nothing but when the patient is lying down on the couch, what is planned outside is exactly precisely delivered onto the patient with a 0.3 millimeter accuracy. So that is called image-guided radiation therapy. So in that way, we are certainly sure that what we are delivering, where we are delivering precisely, and before delivering, we make sure and then deliver it onto the patient. So every day before the patient goes for the treatment, image guidance, that means internal organs are visualized and the target is visualized before delivering the treatment. So this is called image guidance. Besides that, because we are so precise, because we know that the dose is precisely delivered to the target, instead of doing the standard way of 6 weeks to 8 weeks radiation, we are able to deliver in a smaller field, smaller dose and a smaller field. Instead of doing a larger field, we are doing in a smaller area with a high dose of radiation. So that is called hypofractionation. That is possible today in mostly in the prostate and the breast, especially in breast. Instead of doing it for 5 weeks, 6 weeks, we are able to deliver it in 1 week. That is being frequently practiced with us at Apollo. So patients is to really feel unhappy when we tell them that the treatment has to be going on for 5 to 6 weeks. In those patients or in any patients with breast cancer, we are able to deliver it in 5 days. Similarly, prostate cancer treatment used to be for 8 weeks. Nowadays, we can deliver it in 1 week or in 2 weeks or 3 weeks. That is precisely because of the technology that we are able to precisely target. We are precisely able to spare the normal structures around the tumors. So that's the reason why we are able to deliver high dose of radiation in a shorter period. Besides that, most important other area where we are able to deliver 6,000 centigrade in 1 to 3 treatments, which is called stereotactic radiation. Excuse me. So stereotactic radiation is nothing but radiation acting like a knife. When you have a small lesion in the brain, we normally earlier used to ask a neurosurgeon to operate and remove it. These days, it is not really necessary. Without even touching with a knife, without causing any pain to the patient, without the patient realizing that the treatment is done, we are able to do radiosurgery. That means we are able to blast the tumor, burn the tumor without hurting the patient, without patient even knowing that the treatment is done and the tumor is gone. So that is what is called a stereotactic radiation. It could be a small lesion in the brain. It could be a small lesion in the liver. It could be a small lesion in the lung. We are able to deliver, if it is less than 3 centimeters, We are able to deliver entire 6 weeks of radiation in 1 to 3 days. And we are able to get the same cure rates as on par with the surgery. So imagine a lung tumor being operated. The patient has to be in the hospital for 2 to 3 weeks. Similarly, but with radiation treatment, these kind of lesions in stage 1 and stage 2, we are able to treat them as an outpatient. They don't even require admission, and they don't even know that the treatment is done. They would lie down on the couch, the treatment is delivered with a fraction of a minute, and they just walk out, and they walk out freely as if they didn't have any treatment done. So that kind of a sophisticated high gadgets technologies are available with radiation. We are able to make the patient's life easier and calmer, and no radiation burns, and high dose of radiation in a shorter period of time. That also works out economics of the patient. And it's very, very difficult for patient attendants to get the patient to the hospital for 6 to 8 weeks. Now that is no more done. It is done in a shorter and also precisely with less side effects.
Yes, sir. Very well said. I think now at Apollo, it's the first center in the Southeast Asia to be having the proton therapy as well. What is your take on the proton therapy as one of the recent advancements in the oncology management? And which set of your patients could have really got the benefit from this proton therapy? Can you please elaborate us, sir?
Excellent. So, the proton, we are really fortunate that I would call it as a boon to Indian people that we have got a proton, which is the most expensive technology, one of the very most expensive technologies which is brought to our doorsteps in India. And that's, we are very, very fortunate. Going outside, going abroad for proton therapy used to cost nothing short of 4 to 5 crores for any patient to get the proton treatment. Whereas in India, now we are going to be with our family and get the treatment done in our own country with the peanuts compared to the cost what we spend in the United States or Europe or any part of the world. So the proton therapy is nothing but is another form of radiation. It's a particle radiation. And this radiation, compared to the radiation what is existing in the most of the rest of the world, is called linear accelerators, which are non-particle radiation, which are X-ray beams with high energy. Proton is a particle radiation. What is the major difference between these two treatments, X-ray treatment versus proton treatment? Is nothing but X-ray, you cannot stop. It goes through and through. When you treat a patient, let us say this is a target. The beam enters the target and goes through the target, through and through. Although most of the radiation is delivered in the center where the target is, there is some amount of radiation beyond as well. Whereas the proton is the greatest advantage. It hits the target and completely no radiation outside the target. So that is the greatest advantage of proton, which is very, very important because especially in children and in deep-seated tumors in the brain or in the spinal cord. For example, if you are treating the spinal cord, the exit radiation with the standard linear accelerators, image-guided and SBRT, whatever that I said before, there will be 30 to 40% of radiation coming into the abdomen when you are treating the spine. So that 20 to 30% of radiation will not be there with the proton therapy. When you are treating the breast cancer, you have underlying heart and lungs, which can get around 15 to 20% of the total dose what is delivered to the chest wall or the breast, which is again is almost less than 1% when you're treating with proton therapy. So the major advantage of proton therapy is that the spillage of radiation, which is seen by the standard linear accelerators, which are called as X-ray missions, the doses to the critical structures would be almost zero compared to the standard radiation, which is called X-rays or linear accelerators. Is that important? Yes, it is important when a patient has got long-standing heart diseases, lung diseases. Even the minimal dose to the lung and heart also can cause problems. And for the children, when they are growing, this low-dose radiation can also may cause secondary cancers or organ dysfunction in the bodies. So wherever somebody, especially in children, it is certainly proton scores over the photon standard linear accelerators. And also when somebody can afford, which is of course 10 times more expensive than the standard linear accelerators, it is certainly would be, if somebody can afford, proton would certainly add up to reduce the toxicity. In terms of the tumor control, it is exactly the same as the standard radiation.
Thank you, sir. Well, there's a question in the chat box which I'm reading out. It is from Dr. Deepak Avasti. Dr. Deepak Avasti asks, can SBRT be done in liver mets?
Yes, very much. That's a wonderful question. SBRT can be done in liver mets, bone mets, lung mets, and brain mets. So all these areas, that's the target. The SBRT is very much feasible and it is indicated, and we have extremely good results with doing SBRT with liver metastasis, and even for the primary liver cancer if it is not operable.
Well, yes, sir. Moving ahead, exactly in your practice, there might be some cases who would come to you who would require re-radiation. So how do you deal with these patients? And in terms of utilizing your newer technology, what is your take on in this setting? How the newer technology is helping you in delivering the re-radiations?
Exactly. So if newer technologies have certainly helped us in treating patients again if they require second time radiation, or if they get a second cancer in the vicinity of the primary cancer with the original cancer. So all these patients, which sometimes we would certainly look at options of re-radiation, which was very, very difficult in the past because of the cobalt radiation, because of the standard radiation without IMRT. Earlier, we used to get a lot of subcutaneous skin fibrosis, and the internal structures used to get fibrosed, and a lot of radiation changes used to be seen for years together. So doing radiation in those areas again is a very, very, very tough option, and it's going to cause more problems than doing good in these patients. For the same reason, we used to avoid re-radiation in these patients. Now with the new technology, even a patient undergoes a treatment, for example, for the buccal mucosa, and the patient develops tumor at a later stage on the tongue or in the opposite buccal mucosa or the tongue, we are able to comfortably do the full dose of radiation which is required for that particular patient. So similarly, any area which is, most important is the tumors which are close to the spinal cord. The patient has been treated in the past and he requires radiation again. In such areas, proton therapy would certainly be of a big benefit. In case if you can afford, proton is the best. If you cannot, even with the standard radiation, with intensity modulated radiation, with image guidance, we are able to deliver re-radiation even in these areas which are very, very close to the critical structures which have been treated in the past.
Well, just a reminder for all the participants and viewers, please feel free to ask your questions or drop in your questions in the chat box as we are going through the meeting. Moving ahead, sir, I would just want, now that we are now clear about what are the few developments which we have seen in radiation oncology in terms of having proton, how we are able to deliver re-radiation and a very focused and precise radiation treatment with all the image guided techniques we have. Well, our colleague, and even in the medical oncology field, has seen quite a lot of recent developments. So what do you consider as one of the recent development which has really created the buzz is immunotherapy, right? So what is your take on it? Do you think it's a hype or it's a real-time hope to the patients? And what is, can you please elaborate on it?
Right. So chemotherapy patients used to actually, when we use the word chemotherapy, patients used to run away. That's the only reason is that the chemotherapy causes a lot of side effects, hair loss, mucositis, diarrhea, vomitings, all kinds of issues. So most of the times in the past, the chemotherapy used to be a general form of drugs where it affects the cancer cells as well as the tumor cells, the normal cells. So in that regard, the most proliferating tumors or proliferating cells would get affected with this chemotherapy. Any anti-cancer drugs given will have an impact on the tumor cell as well as these normal cells which are proliferating fast. What are the normal cells which are proliferating fast? Are the mucosal areas and the hair, nails, and the gut, intestines. So these things get more affected than the rest of the body. So what happens? You get the mucositis, oral ulcers, diarrhea, hair loss, and vomiting. So these kind of problems were the major problems for the patients to undergo or to come forward for taking chemotherapy. So that is called a generalized form of treatment. We moved from that to next form of treatment, which is called targeted therapy. So the targeted therapy is nothing but identifying the targets within the cells. Earlier, we used to treat the entire cancer cells as a single entity. Now, within the cancer cell, what are the targets which are actually responsible for converting that tumor, that normal cell, into a cancer cell? What are the targets where it got mutated, where the changes have happened to convert that into a cancer cell? Can we block that target? There are plenty such targets within the tumor cell which can be identified, that particular cancer, why it has changed into a cancer and why it is proliferating. So that is called a targeted therapy. So targeted therapy is like targeting that particular target within the tumor cell. It's called tyrosine kinase inhibitors, or antibodies against an antigen molecule on the surface or within the cell. So antigens and tyrosine kinase inhibitors, there are so many targets which have been identified, and that has really changed the overall management of plenty of tumors in the day-to-day cancer management. I would say the classical example is lung cancer. In a lung cancer, in a stage 4 disease, we hardly had patients surviving for not more than 6 to 9 months. Now, with the advent of this targeted therapy, we're able to extend the life by a few more years, starting from 6 months without targeted therapy. If you identify any kind of targeted therapy, we're able to treat them with these targeted agents. Then the patients will respond much better than the chemotherapy, and they would live longer, 2 to 5 to 10 years as well. We have patients who have been just on targeted therapy for years together, even in stage 4 cancer. So the major advantage, apart from having a longer life, is that it is very well tolerated, and most of them come in an oral form, which is a tablet form. So which is much easier to take at home. It's not an injection, and the patients, they respond well and they live longer. So that is called targeted therapy, and that has made a huge difference in majority of the cancers. It could be lymphoma, it could be melanoma. There are plenty of tumors which can be treated with targeted therapy. From there, we moved on to immunotherapy. So we always know that the body can fight the cancer cell. But why it is that the cancer cell is still proliferating in spite of having a proper immunity? So people started working on it, and fortunately they could identify that what is really happening with the immunity of the body, why it is failing to control the cancer. So that is called immunotherapy. Immunotherapy is something that we always used to tell people that thinking positive, building your own immunity, you can fight against cancer. So that is actually true. So what we are trying to do with immunotherapy is nothing but to improve your immunity to try to fight the cancer cell. So what cancer cell does, it tries to block the immunity mechanism of our body. So that by means of blocking a T cell in our body, it is not allowing the immunity to fight against the cancer cell, so that the cancer cell can freely proliferate and mobilize in the body. So that blockage can be stopped by using a drug. And that block, if you stop the block, then our own body will start fighting against the cancer cell. That is, our own T cell immunity will start fighting against the cancer cell. So that is what has made a huge difference in majority of the cancers. But unfortunately, what we thought is not happening in real life, in the sense that we are not able to treat all cancers with immunotherapy with the same intensity, with the same response rates. But as of now, you have a good number of patients, a good number of cancers where we are able to treat them with immunotherapy. We're having a great impact. The greatest part of immunotherapy is that the reactions are, the patient's tolerance is very good. They don't have the reactions that what we see with chemotherapy, and not even with targeted therapy. That the reactions with targeted therapy are also not seen with immunotherapy. So that's the best part of it. The other most important part of the immunotherapy is that not only that the patients respond, but if they respond, this response is sustained. So that will remain for many months to many years. For example, in a lung cancer patient, if he is responding to immunotherapy, even in stage 4, it may remain for years together. So that's the best part of immunotherapy. The only drawback presently with immunotherapy is cost. Because it's a new drug which has come into the market, it is expensive. Although in India, it is much cheaper compared to the Western European world. Although we are getting it in a subsidized rate, still it is very, very expensive to practice for a common individual. But there's a big hope that, of course, even it can be produced indigenously in our market. Hopefully that will be done soon, and we'll be able to get the drug easily and in a cheaper, with a cheaper cost. Then we'll be able to treat more patients in Indian scenario as well.
Well, quite a very elaborate answer, sir. I think it has kind of covered many of the common questions also about immunotherapy, because mainly it comes with a big tag of cost. Well, what in your clinic, what are the usual patients who would be taken up for immunotherapy, sir?
As I said, as of now, the most common cancers that are very effectively that immunotherapy is working is lung cancer. I would say that's the most common drug that we use it in lung cancer. Apart from that, we call them as immunogenic tumors. Immunogenic tumors are renal cell carcinomas and melanomas. Apart from the lung cancer, we use that in melanomas and the melanomas and kidney cancers. Apart from that, we use it in all other cancers where it might have a response, it may not have a response, but if it responds for a longer time. For now, we are using it in head and neck malignancies, bladder cancers, transition cell carcinomas, plenty of the carcinomas we are able to use immunotherapy. For that, there are so many tests that we are still not there. We are trying to identify which are the patients that are going to be benefited by using immunotherapy, but they're definitely not standardized yet. Hopefully that we will be able to know which are the patients that are going to definitely be benefited with immunotherapy. As of now, we are doing PD-L1, we are looking at MSI, we are looking at tumor mutation burden as of now, but we are really not sure whether only these are the targets that we should need to understand before we use immunotherapy.
Well, so while the immunotherapy itself is coming with some amount of cost on the patient's burden on the patient's pocket, what about this test, sir? I mean, how are these tests taken up by your patients? Patient compliance for getting this test done, and what is the usual turnaround time for this test to be available for the patient to start the treatment?
So there are 2-3 things. One is about you're looking at only immunotherapy, then we need to simply do immunohistochemistry test, which is easiest and the best. And that is done in most of the corporate hospitals, most of the big cancer centers. Beyond that, if you're looking at the molecular targets like tumor mutation burden in that particular tumor, you're looking at MSI. MSI can also be done in the hospitals, but you're looking at next generation sequencing, that the mutations and other genetic abnormalities and any gene targets or mutations within the entire tumor, which could be sequencing for around 400 genes in that particular tumor. Then we have to get it done in specific centers where it definitely costs more, and it is in certain patients, in certain tumors, it is still worth it. It costs anywhere from 2 lakhs to 3 lakh rupees in our country, and if suppose these they're sent outside, even cost 3 to 3.5 lakhs. So that is called next generation sequencing. But to simplify it, we can do immunohistochemistry, which costs around 2,000 to 3,000 rupees, and that will let us know at least one target. But if you want to identify multiple targets, these days we have simplified doing this test based on individual tumors. For example, if you are looking at the lung, we look at targets within the lung. So what are the targets which we can identify and which we can target? So we do a lung panel test, which will be cheaper compared to doing the entire next generation sequencing, which is going to cost around 2.5 lakhs. But if you confine yourself to a lung panel or a colon panel or a breast panel, it will be much cheaper. So that's the way we should work out. We should focus on that particular patient Unless it is an unusual tumor, unknown tumor, which we can't define, then we have to specifically ask for next generation sequencing, which is going to be expensive.
Well, how much impact has really immunotherapy or targeted therapy had on the patient survival and outcomes in your clinical practice, sir?
Again, classical example is we used to be very disheartened if you see a patient of stage 4 lung cancer in the past. Similarly, a stage 4 melanoma, stage 4 kidney cancer. Now was a recurrent head and neck cancer, where we had no other options was to tell the patient that your survival is hardly few weeks to few months. Now with this targeted therapy and immunotherapy, we are able to only forbidding problem is the cost, but otherwise, if the patient can afford or if it is covered by some financial assistance, then the immunotherapy has made a huge difference. So there are so many patients in my practice that the patients are in stage 4 we are able to have a good quality of life and prolonged life for years together by adding this immunotherapy and targeted therapy.
So, well, that brings us to one point of understanding that not all stage 4 patients are the same to manage, and not all stage 4 patients will have similar outcomes. And there is a silver lining even at this for the stage 4 patients who can come out with good outcomes, is it?
Yes. So these days, because of the new innovations in the identifying the targets, identifying the mutations, even in stage 4 and different cancers, we are able to have we would call it as actionable genes. Wherever we have targets, which we have drugs available, we are able to control the disease for a longer time. And added to that, most important is without affecting their quality of life.
Absolutely, sir. Yeah. Well, we are looking at some stage 4 patient, and we are mainly looking at what is the quality of life and what less amount of pain we can give to them. So in that way, I think, yes, immunotherapy has added to that. Well, moving ahead, sir, I think the next thing I would like to know from you is Apollo per se for us has been a tertiary referral center for mainly for ocular oncology cases, which are the eye cancers. So you are a senior oncologist who has always been associated with ocular oncology, and you have a vast expertise in treating these oncology cases. So can you please let us know what have the advances you have noticed in the ocular oncology practice and how they have impacted the patient outcomes?
Yes, that's a niche area which I'm really proud of. We started a department way back in 2003, which is Ocular Oncology Center, and the only referral center in the country where we deal with all kinds of eye tumors, especially small children with eye tumors like retinoblastoma, optic nerve gliomas, optic nerve meningiomas. All these tumors are very well taken care of, and we have 99% cure rates in retinoblastomas, and we are able to save lives, we are able to save vision, we are able to save the globe. So that's the way we work on it. And these children, we do all kinds of treatments which are required to take care of these retinoblastomas. We call it as local therapy, systemic chemotherapy, brachytherapy, intraarterial chemotherapy. All these kind of sophisticated treatments are very much available, and they are also cost effective. And we do have support system to take care of socially backward people or people who have poverty issues. So apart from that, we have a lacrimal gland carcinoma, which is another area where it is very life-threatening disease. In most of the centers, not adequately treated, these patients will lead to serious issues, life-threatening issues. So these tumors are also very well managed with us. Our cure rates are very high. We are able to deliver the standard treatments like surgical removal of the tumor and delivering high dose of radiation in the orbit, where it's very, very difficult to treat these areas without causing defects in the vision, and at the same time controlling the tumor. So we deliver around 6,600 centigrade into the orbit, into the area where the tumor is. So that kind of a technology and experience and expertise is with us, and we have developed the department, and safely we do take care of these tumors. So it could be any tumor in the eye, a rhabdomyosarcoma, soft tissue sarcoma, Ewing sarcoma, So any tumors, there are so many tumors that most of the people are not aware of, that the tumors can happen within the eye or orbit. So those tumors are dealt with us comfortably and with great results.
Well, that was great, sir. That's a wonderful ocular oncology practice, which we do have an established department at Apollo Center. Well, I think to briefly summarize about what all the developments which we have seen. In terms of surgery, I think we are looking at something like robotics and minimal invasive surgery. In terms of radiation therapy technology, you have given us an elaborate about how the newer technology and image guidance and stereotactic radiation has made a difference, and the shorter number of visits of the patient to the hospital. And in terms of medical oncology wise, if you see, you can see there's a lot of developments in terms of immunotherapy and targeted therapy, more moving towards personalized medicine with molecular genetics in the background. So can we take some questions from the chat box? Well, as of now, don't find any further questions in the chat box, sir. So, well, it was a great session having, sir. I think we have kind of covered all the aspects of the newer developments. We would like to listen more from you if there is any further developments which you would like to discuss.
Yeah, so today being a World Cancer Day, apart from the developments, we should create some kind of an awareness in society that most important is that the cancer is curable. Today in my clinic, it's so gratifying to see almost 2/3 of the patients what we see every day are cured. And in the OPD, let me say around 40-45 patients, which I see, out of which 30-35 of them are cured and they are just coming for the follow-up. So that's why it's so gratifying to see that we are able to control and cure majority of the cancers. So do not run away from getting the patient diagnosed and getting treatment of cancer. And cancer treatment is no more such severe morbidity and side effects that the people usually imagine. The treatment morbidity has come down significantly and functional outcome is very good. Patients would go back to the society confidently and lead a normal life after the treatment is over. And of course, we need to concentrate on prevention and early detection. So prevention is in, I always say it is in our hands. 50% of the cancers that can be preventable by simple methods, by just doing some changes in your lifestyle management, having a normal balanced diet, do not abuse alcohol, and never get into smoking habits or chewing tobacco, and have a proper regular exercise of 40 minutes per day. It might be boring to do a regular exercise, but you can get into any kind of a sport which has physical exercise, outdoor sport, for 30 to 40 minutes, make a huge impact. So if you do this simple manners, you will be able to protect yourself from developing cancers, and 50% of the cancers that can be preventable, and get a regular screening on par with what you do it for your automobiles. You do send your automobiles for servicing after every 5,000 kilometers. Your body also needs some kind of a servicing, or what I would call it as a screening, that you may have some detection without having any symptoms. So that is where we detect tumors at an early stage. You will get away by doing simple treatments, not a complex treatments, and the chance of a cure are almost 90-95% if you detect the tumor in an early stage. So prevention, early detection, and do not run away from getting diagnosed of cancer and getting treated. Thank you very much for sparing your valuable time. It's been a pleasure to participate in this meeting. Thank you very much, Shilpa, for moderating. You've been wonderful, a good host to be with, and it made my life easier in answering the questions.
Thank you, sir. It was great to have share the platform with you as well. And I think we have kind of tried to cover almost all the aspects of recent developments. Thank you.
Thank you.
ಖತಮ್ ಆಯ್ತು.